Okay, everyone, thank you for joining us today for our webinar. We plan on going about an hour or so. Give a special thank you to Dr. Ken Berley, who's joining us today. Also wanted to let you know that we will be recording the session. At the conclusion of the session in the next few days, you'll receive a thank you email for attending or at least registering if that's the case. And in that email thank you, there'll be a link to this recording so you can enjoy the recording at your leisure. Today, what I'm going to talk about, we'll start with number 4 here, is the ADA came out with a set of guidance documents. There's a couple of documents they came out with, and I wanted to review those in some detail and discuss at a fairly high level some of the implications that these documents carry and the importance that the ADA is stepping in on this subject. Also, Dr. Berley is going to give us a considered opinion, both as a dentist and an attorney. And I think that's extremely relevant because the implications on scope of practice and things of that nature are truly to be considered at this point, especially with the implications that the ADA guidance documents have. And then we're going to finish up with some types of screening and a question and answer session. So let's go ahead and get started. Okay, so let me start off by saying the ADA says dentists should be screening their patients for sleep apnea and should be the professionals who make an oral appliance. In October 2017, the American Dental Association, ADA, adopted a policy on dentistry's role in treating sleep breathing disorders, including obstructive sleep apnea. And this statement is a year and a half old about. And again, this is, a lot of us have considered this to be the case, but the fact that the ADA is stepping in, I think, is a profound change, and will have a ripple effect in dentistry. Okay, let's talk about this in some amount of detail. So in 2015, a full 4 years ago, there was a resolution, 96H, the development of the ADA policy on dentistry's role in sleep-related breathing disorders, which directed the Council on Scientific Affairs, the CSA, to collaborate with other parts of the ADA and develop a policy on dentistry's role in sleep-related breathing. The ADA adopted a literature review evaluating the effectiveness of oral appliances for treating patients diagnosed with sleep apnea. They added 6 new randomized trials to 8 trials that had already existed since their last publication. So there's a full 14 randomized trials that they took a look at to confirm or not the effectiveness of oral appliance therapy. And here's what they've come up with. Number 1, oral appliances work. Great news. We kind of all knew that. And now we have this evaluation of literature review that confirms that. Number 2, oral appliances are typically less effective than CPAP, but better than a non-treated patient or a non-compliant patient from CPAP. And that we all can that's intuitive, I think, for most of us. Number 3, oral appliances enjoy a higher compliance rate than CPAP. So although the effectiveness is somewhat less or slightly less, more people can tolerate oral appliances. And I have a theory on that. And the easy thing to imagine there, or a popular theory, is that if you describe oral appliance therapy to a person and you describe CPAP therapy to a person and you say, which one do you want? 9 out of 10 of them are going to select an oral appliance because it just sounds like an easier thing to do. And I think there's some of that in the reason why oral appliances have a higher compliance rate, but I don't think that's the bulk of the reason. In my opinion, the reason is follow-up. And when you're managing any type of chronic condition, and sleep apnea is certainly that, a chronic condition, but when you manage any chronic condition, high blood pressure, congestive heart failure, COPD, asthma, name any long-term issue, careful follow-up is the key component to successful treatment. And with dentistry, and especially how oral appliances are administered, it requires follow-up. You can't just give a patient an oral appliance and say, here you go. That's kind of what happens with CPAP. You know, they get one session with a respiratory therapist, and then if they're lucky, they'll get a couple of phone calls. With dentists in oral appliance therapy, obviously we couldn't do that. So I think the follow-up that's required to administer oral appliance therapy is a major component as to why compliance rates are higher. Number 4, there's not enough good data on pediatric oral appliances. And I would say on that, my opinion on that would be that treating patients, pediatric patients with an appliance, widening the palate or what have you, that's even more new than an oral appliance in adults. So I think we need some time to get this literature or get this research done, but I think we should really start focusing on it. And the reason is if we correct the issue as a pediatric patient, what would be fascinating to find out is, are we going to see a reduction in the incidence of sleep apnea in these adults? Okay, it's so new. A lot of kids that are getting treated aren't adults yet, so we really don't know. But that would be a fascinating thing to find out. And then there's no good data on follow-up. And I know I mentioned this on number 3, but by follow-up, I mean for the sole purpose of establishing how a person's doing with their therapy. And there's not a lot of that goes on. With dentists, because you're involved in treating the patient over time because of the titration process, you're involved with the patient over time, not necessarily just for the purpose of seeing how they're doing, but you're maybe taking the mandible out another millimeter. Maybe there's some TMJD issues or what have you, and you need to manage those types of things. So in the course of initiating treatment or offering treatment, there's kind of implied follow-up. What number 5 is talking about is, once the person's, at the optimal mandibular position and they're doing well and they're off and running, they're doing their morning repositioners or whatever the case might be, that your office calls them or they come in just for the purpose of seeing how they're doing, and there's not good data on that. Okay, moving on. Let's talk about the diagnostic process for a moment. Diagnosis guided by physicians. PSG, polysomnogram, is preferred, but HST is accepted. And that's a fairly straightforward thing to say. But I think when people say PSG is preferred, it's almost, I don't know, it's almost like the politically correct thing to say, because the PSG is not even the same test as an HST. And let me explain to you really quickly the difference the way I see it. A PSG is designed to rule out any number of sleep disorders. There's 5 or 6 that we all look at is from the sleep lab perspective. Obviously sleep apnea, upper airway resistance, periodic limb movements, seizure disorders, narcolepsy, parasomnias, movement disorders. These are kind of the top, 4 or 5. I think in the literature, there's probably 80 or 100 types of sleep disorders. We really don't look for, all that, but we look for certainly 5, 6, 7 sleep disorders when you do a PSG. An HST, there's one reason to do an HST. You're looking for the functionality of the airway, and that is it. And we're doing it on a healthy adult. So HSTs are very, very narrow in their scope. And to me, it's a much easier thing to subscribe to or to dispense or talk about, because it is very narrow. You have a healthy adult and you suspect they have sleep apnea. Okay, that person qualifies for an HST administered by a physician. Okay, there's not much more to HSTs than that. PSG's a different story. So PSG preferred, substantially equivalent to HST with regards to assessing airway issues, and this is true. In some ways, I believe HSTs might be better. PSGs are more comprehensive, and I've talked about that, and it's simply because they record more channels, they're attended, and they have a wider range of indication. okay? I would like to mention that DDME, the company that I manage, uses the Knox T3. And this is a HST. The reason we use that device is it is the most competent device, in my opinion, for detecting complex sleep apnea, upper airway resistance, RERAs, and it's highly accepted in the medical community. And remember, we'll talk about this in a minute, dentists need to work with a group. One of the groups is physicians in the medical community. The Knox T3 is very accepted in that group. And if you're going to work in that group, there are certain things they're going to ask of you. And one of them is to use a device, if that's the situation, that they're familiar with. And certainly they are with that device. Okay, CPAP. Let's talk about the treatment options. CPAP is the best treatment option for severe sleep apnea. We know that. You know, that's pretty common knowledge. I think if I've been to 100 courses on treating sleep apnea, every one of them said if you're severe, CPAP's best. So I don't know that anyone's gonna go run around shocked by that statement. Oral appliances are preferred when CPAP is not accepted or tolerated in mild to moderate cases. So the implication there is if somebody is not tolerating CPAP and they're severe, they need to try harder. You need to push a little bit harder. Say, listen, we really do need to, you know, what is it specifically about your CPAP? You know, and even though this really technically isn't the dentist's job, I think you would do yourself a service. If you have a severe patient and they say, geez, doc, can you make me an appliance? I just can't deal with CPAP. Find out specifically what it is about CPAP they can't deal with and have a conversation with their provider of CPAP. And I'll tell you what, there's two reasons for that. One, it's clinically, it's a very sound approach. And two, you will be perceived in a different way if you call the physician who's prescribed CPAP and says, hey, physician, your patient here is wanting me to fabricate a custom oral appliance. They're a severe case, and it turns out that it seems like the mask is causing them a sore on the bridge of their nose or some, whatever the case might be, to have that conversation. If you have that conversation with a physician, they will see you in a completely different way than if you call them and say, hey, listen, I took a course and I'd like to help treat your patients with an oral appliance. It won't be the same, and you'll have opportunities that if you become more perceived as a CPAP advocate on the medical community, that you won't have if you're soliciting your services. Okay, just a little bit of advice there. Most common oral appliance side effects. I mean, this is important. CPAP has side effects, not a lot of them, but they do. And as do oral appliances. So oral appliances have side effects. One is excessive salivation, TMJD issues, and orthodontic changes. I think bite changes, that is so common. It's almost not like a side effect. It's almost like you can expect that will happen and you should manage it, okay? Because it is so common. Okay, moving on. Using oral appliances to treat patients diagnosed with sleep apnea enjoys nearly all the same health benefits as CPAP, including improved quality of life, decreased medical comorbidities such as high blood pressure, and so on. Okay, huge statement. This goes to exactly the difference between a failed CPAP and an oral appliance is better than a failed CPAP. And let me explain to you what I mean by that. If you have somebody on CPAP and they can't tolerate it and they say, sorry, doc, I tried, I just can't deal with it. And they go back to having an AHI of 30, let's say. And then they go to your office, you fit them for an oral appliance, and you get their AHI from 30 to, let's say, 9, okay? So some would say, well, is 9 treated? Okay, well, you know, if you can get it below 9, by all means, do that. But sometimes with an oral appliance, this is what we're talking about, effectiveness. 9 is not an achievable, you know, getting the AHI below 9 is not achievable with an oral appliance, considering, you know, all the factors involved. And 9 is the best that you can do. Is a person, this is almost a silly question, is a person better off with an AHI of 30 or 9? Okay, this is what we're talking about when we say at least it's better than not being compliant at all. And if you get somebody at 9 from 30, that's a very big difference, huge difference. And some of the things that have maybe some of the health medical comorbidities that are difficult to manage with an AHI of 30 can be managed with an AHI of 9. Okay, so this is a very important thing to consider. Okay, so let's move on here. The patients can be treated for snoring. So let's talk about snoring. The reason that this is important is, and I will tell you, from the medical side of things, we really didn't think or talk about snoring all that much, to be honest with you. You know, people would come in with a complaint, and then there would be an extensive intake, very targeted on sleep. And we would determine that this person has a high likelihood of something, and it was almost never snoring. It was always sleep apnea or some other sleep disorder. So this is not necessarily the case in dentistry, because I think in dentistry, the patient perception is my dentist can help me with snoring. So this is the reason a lot of patients come through your front door. So it's an important question. So here's what the guidance is on that. Patients can be treated for snoring with an oral appliance. However, it is recommended, and I would add highly recommended, that these patients be evaluated for OSA. For those of us that have been doing this for quite a while, you know the incidence of snoring and no sleep apnea is low. Okay, but why is snoring the thing that brings it in? Because it's perceived, it's known. People know that they snore. Their spouse tells them they snore. They wake themselves up on a plane snorting. You know, these are the things. This is one of the sleep disorders that a person perceives. So by all means, say absolutely, we'll evaluate you for snoring, and let's do an intake and let's find out what's going on. You know, I think that's the best way to do it. And then the guidelines concluded the application of oral appliance is highly desirable in cases of simple snoring or mild to moderate OSA, whereas considerable caution is warranted when treating severe OSA. Okay, we're kind of being a little redundant there, but it's important. And when you're talking to a person that is sitting in your chair because they want help with snoring, and then you determine that they have a high likelihood of severe sleep apnea, there was a conversation to be had there. And the conversation is, okay, you know, it looks like you're a high likelihood of severe sleep apnea. I think the best way to handle this, including your snoring, is to get you over to the sleep lab or to a pulmonologist that you're working with, okay? Let's talk a moment or two on the pediatric airway management. This is, again, probably one of the more newer components to airway. And so here's the statement that was made in one of the guidance documents, is they wanted to investigate the efficacy of orthopedic mandibular advancement, or RPE, rapid palatal expansion, in the treatment of pediatric below 18 patients with obstructive sleep apnea. Although the studies are limited, these orthodontic treatments may be effective in managing pediatric snoring and sleep apnea. Other related health outcomes, such as neurocognitive cardiovascular functions, have not yet been systematically addressed. And I will add to that there is, we've all heard of the spectrum disorders, ADHD and so forth. And those patients have a similar set of symptoms as patients that have a sleep issue. Okay, so I don't want to imply that one is the other. I think they're two distinct things, but in reality, when we're evaluating these kids, if you go down the symptoms, the list is very similar. So it's hard to distinguish, is this a kid with an airway issue, or is this a kid that has a attention deficit disorder or what have you? So the idea here is, when we do these evaluations, it's important to understand that there is a cross-section on those patient types. Okay, next, the dentist can do, and and this is kind of, we're going to summarize a little bit here. Dentists can and do play an essential role in the multidisciplinary care of patients with certain sleep-related breathing disorders and are well positioned to identify patients at greater risk of sleep-related breathing disorder. Okay, so what does that mean? Well positioned. Is a physician well positioned to do the same thing? Absolutely, they are. Without question, they might even be better positioned. However, the way dentists care for their patients and the way physicians care for their patients, due to just I'll call it the business model, dentists, I believe, are in a better position just because of the nature in which dental care is administered is conducive to identifying these issues. Okay, so for example, when you're patients in for cleaning, you're already looking in their mouth. You're already asking them certain questions. They're there for a while. They're there for 30 minutes, an hour, whatever, depending on the procedure, obviously. In the physician office, a physician gets about 3 to 4 minutes with the patient, and then that patient's there for something besides sleep disorders almost all the time. So a physician almost always has to say, hey, listen, by the way, I kind of just might be out of the blue. Are you tired during the day? That just does not happen enough. It doesn't. It should, but it doesn't. So this is why dentists, I believe, are better positioned to identify the issue, and it's important to identify the issue than physicians. It's for the reasons that I stated. Dentists are encouraged to screen patients for sleep-related breathing disorders as part of a comprehensive medical and dental history to recognize symptoms such as daytime sleepiness, choking, snoring, or witness apneas, and an evaluation for risk factors such as obesity, retinopathy, hypertension, and so forth. If risk for sleep-related breathing disorder is determined, these patients should be referred as needed to the appropriate physicians for proper diagnosis. Okay, very straightforward. The key is identifying the patient. Get the patient on the treatment track. Okay. Physicians, like I said, they're already challenged with what they're tasked with, let alone asking them to add on to what they're having trouble doing already. Okay. The question that I have, and this is a rhetorical question. Okay, now that the ADA is taken a position and offered guidance documents, the rhetorical question is, does this indicate standard of care is now implied to screen patients? Okay, it's an interesting question. It's not a controversial. It's a pretty basic question, but it should be one that we should consider, start talking about. If your patient was involved in a sleep-related accident and you did not screen them, are dentists in a weak position due to this guidance? I think not, to be honest. My personal opinion, maybe I shouldn't even get it, but I think it's kind of early for that kind of thing. I think what will happen is if there's ever kind of a lawsuit in this area, then that might come to pass, I think. But for now, it seems it's maybe a bit early. I can tell you on the medical side of things, that's not the case, and I'll give you an example. Years ago, I was doing a sleep study on a truck driver who, as a result of an accident, 2 people were killed, and he fell asleep, rear-ended a car. That car pushed a car into another car, and the second car up is where the 2 people were killed. And that person had taken it upon themselves to go to a sleep lab to get diagnosed, but they fell through the cracks, and they never were given a CPAP. They were never given treatment, because on the medical side, there's a handoff from the sleep lab to a DME provider, which provides CPAP. That did not happen. And this person went diagnosed but untreated for some amount of time, and then this accident occurred. And the truck driver's attorney said, okay, there's some amount of this, obviously, that needs to be assigned to the individual or group that did not administer treatment. And that was the reason that we were doing the sleep study. So it's that type of thing that already goes on the medical side. And at some point in time, this may be something that we consider on the dental side. Okay, next. In children, screening through history and clinical examination may identify signs and symptoms of deficient growth and development, or other risk factors that may lead to airway issues. The vaulted palates, the tongue ties, there's a number of things that you can look at in a pediatric patient that tells you that there's an issue. But what's different in children is the role that the parents play in identifying the behaviors, the neurocognitive development delays, the developmental delays, the speech impediments, or what have you. Those are identified through patient parental observation. So it's important that we understand that, I hate to say this because we all know this, but it's not based on the AHI for pediatric patients. It's much more how's the child developing, and let's look at it from a set of questionnaires, and let's see if this patient's demonstrating developmental delays in any number of areas. If you do observe behaviors or physical symptoms of sleep-related breathing disorder, intervention through medical dental referral or evidence-based treatment may be appropriate to help treat sleep-related breathing disorder and or develop an optimal physiologic airway and breathing pattern. Okay, so this is just essentially saying that just as in adults, children, and to be honest with you, I think it's even more important with dentists seeing kids, because we're already seeing them for other reasons frequently. So it's fairly easy to identify these kids from an exam, and hand their parents a questionnaire and say, in 2 weeks, come back and let's go through this questionnaire. What could be easier than that? And so finally, the parents' role in identifying these kids cannot be overstated. And do you have a questionnaire? It's pretty simple. The questionnaire is so much more important with the kids. Okay, final thoughts. Treating OSA using oral appliance when prescribed by a physician is within the dental scope of practice. Great. According to the ADA, not only the AADSM. The AADSM, not to minimize their role in this, but the ADA is the group. Their legitimacy is not in question. They have purview over all of dentistry, and so they're representing dentists to the whole of people, that the stakeholders in these patients. Okay, all dentists should screen patients for sleep disordered breathing. How is this implemented? Screening could be a few questions, but may also be some type of objective data, as sleep disorders are difficult to identify due to when they occur. Okay. Case in point, when I started learning about parafunction and bruxism, I did my own literature review and started reading up, and the vast majority of bruxism research is giving a questionnaire to a person that has tooth wear. That was most of the subjects. Patients were identified through tooth wear and given a questionnaire. Okay, so it's difficult, especially with movement disorders. You really do have to be asleep. It's almost, not many people wake themselves up grinding their teeth, although I suppose it could happen. To ask a person a bunch of questions about their bruxism is fairly weak research, because of so much of parafunction occurs when we sleep. Obviously not all of it. There's the daytime and nighttime. So I'm talking about the nighttime bruxism. And to ask a question is almost laughable. Each dentist should ask themselves, is screening something that I should start doing? For sure, so that you should ask yourself. And then if you answer the question, and then to what extent? Do you just want to add a couple questions to your intake and refer out? That's fine. That's screening. That's a perfectly acceptable way to go. If you start screening, have a place to refer to, sleep labs, dental sleep medicine experts, or what have you. So if you say, yeah, you know what, it's probably a good idea. It's good for my patients, and I think it does good service. And maybe down the road I'll get into it, but initially I want to at least start screening and referring out. Then if that's the case, then find a local sleep lab or board certified physician and or dental sleep medicine person that's in your area, that when there's a positive response to your questions, you have something you can say to do. Okay, say, listen, I noticed you filled out the questionnaire and it looks like you're tired during the day and your wife says you snore. Listen, I'm going to refer you to Dr. Berley or Dr. Carstensen. They're experts in this area and I think they can help you. And here's their contact information. I'd like you to schedule an appointment. You're done. Boom. It's that easy. Okay. When oral appliance therapy is prescribed by a physician through a written or electronic order for an adult patient with obstructive sleep apnea, a dentist should evaluate the patient for appropriateness of fabricating a suitable oral appliance. Okay, so what does that mean? You get a referral. Is this patient a candidate for an oral appliance? Okay, so with CPAP, there's very, very few reasons you can't do CPAP. Alveolar hypoventilation. Okay, you puff up their lungs. Notwithstanding that, which is extraordinarily rare, most anybody can, one way or another, deal with CPAP, at least from a physical perspective. Not true with oral appliances. There's more reasons why a person is not a good candidate for an oral appliance than there are more reasons why they can't do CPAP. TMJD. Is there a joint issue already? Do you want to be putting more pressure on a joint that's already got issues? A dentalist patient. It might be silly to think that you would get a referral, but there's a certain amount of teeth you need, and to be honest, there's even ways around that. That for the most case, does the person have a gag reflex? Are there mobility issues? If you end up getting an appliance that's too tight, and then the teeth start moving too much, So these are some of the considerations when you get a referral. Okay, important to consider that. A dentist should obtain appropriate patient consent for treatment that reviews the proposed treatment plan, all available options, and any potential side effects of using oral appliance therapy and expected appliance longevity. Ken Berley has a number of documents, and there'll be a way for you to get one or more of these documents at the end. We'll talk about that. But that's important. I mean, we're treating a medical condition. On the medical side, this is common knowledge. It's not that it's not common knowledge in dentistry, but it's important because as a dentist, you're treating a medical condition. Okay, dentists treating sleep-related breathing disorder with oral appliance therapy should be capable of recognizing and managing the potential side effects. We kind of already talked about that, TMJD, orthodontic changes, compliance, and so forth. Okay. All right. We're going to introduce a good friend, Dr. Ken Berley, who is a dentist, learned in dental sleep medicine, and also a practicing attorney. And I think, Ken, again, thank you for joining us today, and I'm going to turn the meeting over to Ken.
Hello, I hope everybody's there. To let you know, I'm the guy that's the dentist attorney, and there's a lot of attorneys around, but I'm actually licensed to practice law, and I do actively defend dentists who unfortunately have gotten in trouble. So, but anyway, the first thing you need to understand, don't consider this legal advice, because number one, I may not have an exact understanding of your situation. If you want me to know exactly your situation, please pick up the phone and call me, and so I can get the research together and know exactly what I'm talking about when I speak with you. But anyway, I'm not giving advice. There's a big problem in dental sleep medicine. And the problem is, it is the only area of dental practice that when we discover that a patient has a problem, we aren't free at this point in time to provide immediate treatment. That presents a lot of frustration for dentists. The way the current protocol is set up, all patients with sleep disorders must be diagnosed by a sleep physician. That is a good thing and a bad thing. The bad thing about a sleep physician having to diagnose OSA is there are a little less than 4,000 sleep physicians in this country. Here we have over 150,000 dentists who are just being ordered, or not ordered, but encouraged by the ADA to begin a screening program. Well, if each dentist screened 10 patients that likely have OSA and referred them to a sleep physician for a diagnosis, obviously we're going to collapse the system. So right now we have a serious numbers problem. But a sleep physician is extremely knowledgeable in sleep disorders. They are certainly the experts with the most knowledge and the best sense of understanding what patients need for successful treatment. The other thing is that not only do the sleep physicians have to diagnose them, the diagnosis is a result of an overnight sleep study, as Jeff was saying, of some type. It can either be an in-lab study or an HST. It must be then read by the board certified sleep physician who provides the diagnosis. As a result of that, the sleep physician diagnoses the patient, and before we can provide an oral appliance, we must receive a written order or a prescription from that sleep physician to you to treat the patient. The reason for this is that oral appliance therapy has been placed inside DME, meaning durable medical equipment. So we can't provide durable medical equipment and get insurance companies to pay for it unless we actually have a written prescription by a physician. And that has to be coupled with a letter of medical necessity signed by the physician for us to now treat that patient, file medical insurance, and receive a benefit for that patient from their insurance company. So those are the problems we must overcome before we can provide treatment. So there's basically, unfortunately, two approaches that have been applied in dental sleep medicine. The first approach is what I call the sleep physician dependent approach, which means all of your patients get referred to a sleep physician. The sleep physician then distributes the patients as he deems appropriate. And ultimately, many times after the patient fails CPAP, then they begin to be referred to us. There are also, and the last time I added them up, something like 42 different organizations that are treating something that I call an independent practitioner approach. Now that's my name, but these groups don't necessarily think that a sleep physician exam is required. They think that no PSG is required. The prescription that they get to treat the patient is from a non-sleep physician. Many times these prescriptions come from a PCP, internist cardiologist. They're using HST and not a PSG. The problem with this is that there are a number of sleep disorders that create symptoms that are not going to be picked up by an HST. So the liability from a dental standpoint is the dentist could be completely responsible for the health of the patient. So those are the two general approaches that we have right now. The reason why most dentists are gravitating toward the independent practitioner approach is that in my personal practice, I referred 82 patients to a sleep physician before I ever got one to treat. And to say that's frustrating, is an understatement. The good of a sleep physician approach is there's no direct cost to obtaining the patients. Obviously, the referrals come directly from the patients, and it's easier to legally defend. It allows you to file all the private medical insurance and Medicare. Excuse me. But the bad is it's difficult and time consuming to get established. And again, as I say, there's a huge risk that you'll refer your patients to a sleep physician and they will never be offered oral appliance therapy. And the 82 to nothing is how many patients I referred. So that's kind of the background that we have. We're kind of in a almost non-workable profile or protocol right now, and hopefully over the next few years some of this will be modified, but that's actually what we're putting up with now. So the problem is if you don't follow the AASM protocol right now, the risk to dentists is that they can be turned into their board of dental examiners and their medical board for practicing outside their scope of practice. And the scope of practice is the procedures and actions and processes that a dentist is permitted to undertake and keep their license. So scope of practice is not really something that dentists have ever had to defend, because if you look at the definition of the practice of dentistry, it is so incredibly broad. Virtually everything in the maxillofacial areas within our scope of practice. But sleep physicians who have a great lobby have carved out sleep disorders, which obviously are caused by the tongue and the pharynx and the soft palate. They've carved that disorder out of our definition of the practice of dentistry and said that specific part of our definition, we can't touch it without them saying we can. So dentists who are unfortunately ordering HSTs are now being turned into their boards for practicing outside their scope. The good news, I've defended a number of these to this point, and nobody has been sanctioned, but no one likes being turned into their board for anything. So that's the major frustration we're facing. When you look at scope of practice, there's actually three elements of it. Number one's the state definition of the practice of dentistry. The second aspect is your educational level. For example, both general dentists and oral surgeons work under the same definition of the practice of dentistry in the same state, and yet their education levels changes their scope of practice. Obviously, oral surgeons might be qualified to do a number of things that a general dentist wouldn't be qualified to do, but yet they work under the same definition of the practice of dentistry. The third aspect is any limiting state statutes or board opinions. In other words, if the State Board of Dental Examiners has visited this subject and said you can't do that, then it is not within your scope. I didn't put it in this lecture, but Georgia has specifically promulgated a statute on sleep disorder breathing, and specifically said dentists in that state cannot use HSTs. That's unfortunate because obviously the ADA policy statement does say we can. So, but anyway, I'll get to that in a minute. So anyway, those are the elements of our scope of practice, which we're now defending. So anyway, the typical case that you get is State Board of Arkansas, for example, versus Ken Berley DDS. And these are dentists that are being reported to the board primarily by Blue Cross Blue Shield. And that's unfortunate because what is happening is these dentists are being encouraged, usually by different billers, to bill Blue Cross Blue Shield for the HSTs that they are doing, and Blue Cross Blue Shield is then turning them into the Board of Dentistry for practicing medicine or practicing dentistry outside their scope or practicing outside their scope. So that's the kind of thing that we're dealing with on there. I'm assuming y'all know that the AASM has teamed with the AMA to defend the scope of practice of physicians against the advancing care providers who manage obstructive sleep apnea, and they're trying to protect their scope from encroaching dentists. And they've done this by passing this resolution, which says that dentists can't order or interpret objective tests, and the appropriateness for tests and the evaluation of the effectiveness of the test, constitutes the practice of medicine. And even ordering the objective test has to be done by physicians. The unfortunate part about this resolution is they sent that to every board in the country. And unfortunately, I just had a dentist in Pennsylvania turned into the medical board for practicing medicine without a license. And unfortunately, that's a felony. So, the good news is we got it all dropped. No charges were actually filed. But these are just unfortunate instances that hopefully are going to be resolved in the near future. I didn't see Jeff's slides until 5 minutes ago, just like y'all, and I really don't want to go over the same things that he's gone over, but I've put some different things from the policy statement in here. And the big deal is that the ADA carries a huge amount of weight when they get involved in any role or any part of dentistry. And obviously, we are claiming sleep disorders as being an official part of the dental profession with this policy statement. And obviously, it says that dentists play a significant role, as Jeff has already told you. They're the one that is well positioned to identify patients at risk for sleep disorder breathing. It also says that we should collaborate with the medical profession and work in conjunction with our colleagues. In children, we should be, looking for suboptimal growth and obviously recognizing those issues, primarily in children. And I don't have time to go in. Oh, by the way, for those on here that don't know, and I'm assuming that's Steve that's on the line, Steve and I are doing a 2-day presentation at the ADA on all of the ramifications of the ADA policy statement. And that is right after Labor Day, September, I think the 5th and 6th in San Francisco. So if you possibly can, please come join us in that meeting. And the good news is that anyone that attends that 2-day lecture will get a free copy of our book. So, but anyway, we should be going in and looking at children and trying to identify them early. And if we're not treating the kids, we need to find somebody locally that is able to actually expand the airways, open up the arches on these kids, and hopefully cure them at an early age, as opposed to treat them later on in life and hopefully just control the damages of the disease. But anyway, we're supposed to be looking at kids. The biggest thing in this is that the ADA policy statement basically said dentists are the only healthcare providers with the knowledge and the expertise to provide oral appliance therapy. That's just a huge statement, because many MDs are now coupling with different dental assistants and different organizations that they're putting in their offices, and the MDs are now providing oral appliance therapy. So the going back to Jeff's comment about lawsuits, any patient that doesn't respond well for that that office that doesn't employ a dentist, there could be some legal risk involved in that. I'd like to discuss what Jeff was talking about where this is going to go legally. And obviously, it's hard to know exactly what will happen in the near future. However, I think we can look back to 2010, I believe is the exact date, when the ADA went in and passed their policy statement on screening for oral cancer. I think that was done in August of 2010. Well, it took a little while for attorneys to find that policy statement. But once they found the policy statement, they began to look for cases where oral cancer occurred and the dentist never documented that they screened for oral cancer. So in the policy statement number 1, dentists are encouraged to screen, and then the patient should be referred as needed to the appropriate physicians. I think within a reasonable period of time, if a bad outcome happens to a patient that obviously has OSA, there is potential for liability, but it's not nearly as high as it is for the patients that turn up to have oral cancer, because there's so many things that affect sleepiness. There's so many things that affect whether the patient has a stroke or heart attack. We would have a great defense to go in and say, yes, the patient could have had OSA, the patient that could have contributed to them falling asleep on the highway and dying, let's say, but so could the fact that they're 50 pounds overweight. So this is much harder for a plaintiff's attorney to grab and run with, because the direct cause and effect is not there. Okay, there's so many things that can affect a bad outcome for a sleep patient, whether it's medical risk or whether it's accidents. I'm hoping that we would never see a flood of cases, but I'm sure we'll see a few, and there'll be test cases. What it would take for this to make a real splash would be a case where the damages are so big that a plaintiff's attorney will take it just to see what happens. For example, a patient comes to me and they look just like me. They're 270 pounds with an 18-inch neck. Dad died of a stroke in the middle of the night. You know, an obvious OSA patient. If that patient came to a dental office and complained maybe in the record of not being able to sleep well, and the dentist did not refer that patient, okay, and he fell asleep and hit a school bus and killed 8 kids. Now we've got an obvious patient that a reasonable dentist should have known to refer. The referral wasn't made, and now we have 8 dead kids, so tons of damages. That's the kind of case that all of a sudden makes it to court. Would it happen? Could it happen? Yes. Do I expect it? No. Okay, children screening. And it's kind of interesting that we're talking about screening because that's been a discussion with Steve and I for quite a while. There's a number of different things that can be used to screen. There's the bear screening and all this kind of stuff. But if you just ask the parents, is this child snoring? If you look in the mouth and see if the child is crowded, if you look for big tonsils, if you look to see if they're mouth breathing, tongue thrusting, venous pooling under the eyes, the typical kinds of things, you're going to pick up on a whole lot of these kids. Also, and I don't know the exact percentage, but maybe as many as half of them have what I call the alphabet disease. In other words, the ADHD or the ADD, hyperactive kids. So, but anyway, kids should be screened, and we have the same factors there. Oral appliance therapy is primarily for mild or moderate by the ADA standards. It's kind of interesting because that's more conservative than the DABDSM standards, which now says for anyone. But I tend to agree with the ADA. In my practice, if I've got a severe patient, I encourage them to try CPAP first. Not that I think that oral appliance won't be effective. I just think that from a legal risk standpoint, I think I need to offer them CPAP. So anyway, oral appliance therapy must be prescribed by a physician. We've discussed that. Dentists should obtain appropriate consent. Dentists need to know how to handle the side effects of this, or don't do oral appliance therapy. Again, Steve and I are going to go through all of this in our lecture at the ADA. The big deal, and this is the huge deal that changed our approach to dental sleep medicine. The ADA, or excuse me, the AASM and the AADSM had never agreed that we could use any type of type 3 or type 4 testing or monitoring to help titrate our appliances. And that's an absolute shame. I think for anybody that's doing a lot of these, you know that you just get better results if you're doing some type of monitoring. Everybody has their own way of doing it. You know, I think before my patients go back for a final PSG, I use at least one HST and get, you know, some data on them before they go back, and I think that's absolutely critical. The big deal, okay? people call me up literally all day long and say, Ken, can I screen my patients with an HST? Can I use a type 4, a high resolution pulse oximetry? Can I use a Gym Pro to screen with? What can I do? Well, the problem is any and all of the above can get you turned into the board exam or to the state dental board. But what you need to do, this is kind of a modified letter that I sent to my sleep physicians. When the ADA policy statement came out, that was just after the AASM sent around the statement that not only can we not use HSTs or Harpos or any of those other things, I sent all of my physicians a letter and said, look, we have all of these conflicting policy statements, and I want us to get together and come up with how we're going to treat our patients in Northwest Arkansas. So I took all of them. I have 5 sleep physicians that refer to me, and I took all of them to Ruth's Chris, got them all liquored up. No, we had a good time. And I talked about the ADA resolution and the AASM resolution, and I gave them specific examples of the kind of patients that really worry me. For example, a patient comes to my office and she's 25 years old and she has symptoms of TMD, I mean, significant TMD symptoms, and she says she sleeps like the devil. I mean, she just thrashes everywhere. She's exhausted. So, is this patient who has all of the TMD signs and symptoms, is she just a TMD patient that can't sleep? Is she a sleep patient with TMD signs and symptoms, which we all know occurs, or is she both? So the problem is, as many 25-year-old patients, she's got a $5,000 deductible, and if I send her to my sleep physician, he's going to put her in the sleep lab, and she's going to pay the whole cost of that sleep lab out of her pocket. And if she turns out not to have OSA, she's going to be mad. So in my world, in Northwest Arkansas, I've got an agreement from all of my sleep physicians. They want me to do an HST type of screening on her before she ever goes to see a sleep physician. I don't send that to be to be scored. I don't send that to a sleep physician. It's computer scored just as a screening. But I would never tell another person to do that in your area unless every sleep physician that you refer to knows you're doing it, has encouraged it, and will back you up if you're ever turned into the board. So my comment usually is, with the right relationships, with your sleep physicians, you can do almost anything you want to. If you haven't established the kind of relationship where you can pick up the phone and talk to all your sleep physicians and discuss what they want to do, don't do any of this. So what can I tell you can absolutely do? If you go in and use HSTs or Harpos to titrate your patients, that is absolutely legal in any jurisdiction. Even in Georgia, I would defend you, and I think I can get you off, because the ADA is going to have lots of impact, you know what I'm saying, in that board complaint. But if you do anything other than what's in that ADA policy statement, we don't have, you know, the basis yet in place to say that any of that is legal. Now, dentists literally all over the country are screening with HSTs and doing all of those kind of things. The problem is, you know, we're not there yet. But the good news is the ADA is well aware that there's a problem. There are things in progress that hopefully will open this up in the future, but it's not there yet. So anyway, my suggestion would be get in touch with your sleep physicians and see if you can have an agreement on what protocol you're going to follow, and follow whatever they say. Because if I personally get turned into the board, my sleep physicians are going to be the first ones I'm going to call and say, hey, I need you to go help bail me out. So anyway, my only regret is that I didn't start sooner. This is a picture of my dad about 2 weeks before he died of a stroke. And he had horrendous sleep apnea. I wasn't smart enough to know it. He snored terribly, and I'm always reminded of my lack of knowledge by looking at this picture. So anyways, I went over my 15 minutes. Certainly anyone with more questions, contact me. My email is dsatsleep, and I'm going to give this back to Jeff, and take it away.
All right, thanks, Ken. That was fantastic. I appreciate your effort. And so let's see here. I'm going to wrap things up. I have a couple of topics that I want to bring to everyone's attention. And so just wrapping up, there was a couple terms that both Ken and I used, screening. And I wanted to just spend a couple of moments going through what that means. One of the options that you have is, and I mentioned it earlier, is just add some questions to your intake. Are you tired during the day? And there's questionnaires to assess, daytime sleepiness. Has anybody reported you snore? Has anyone noticed pauses in your breathing while you sleep? Do you have morning headaches? And the good news, the way I see it, is if you get a bunch of yeses and you're not ready to get started, refer them to a sleep lab. And you've screened the patient. It's that simple. This doesn't have to be, much more complicated than that. Questionnaires, there's a lot of them available. The Epworth Sleepiness Scale is a very popular one. It's popular with insurance payers for one reason or another. There's a Stanford Sleepiness Scale. There's a number of them out there. And again, I think when you're going to start working with a physician, they're going to have a questionnaire they like, and just use that one. And then the third option would be to collect some type of data. I'm a big fan of data collection for two reasons. One, I make my living selling data collection devices. And two, sleep is a difficult thing to self-assess. So the obvious, it's almost a joke, is how do you know that you have pauses in breathing? Well, if you have a bed partner and they notice or whatever, but it's hard to ask your, and just as a little quick side story, when I started learning about pair function and bruxism, almost all the data was questionnaires on, do you grind your teeth at night when you sleep? Okay, well, how's a person really honestly supposed to be accurate on that? So in any event, so that's why I like data collection. Oximetry. DDME has an oximeter. Ken talked about the high resolution pulse oximetry. And HSTs. DDME uses the NOx-T3. It's the most popular home sleep testing recording in the medical community, and we interface with the. Hold on. Sorry, guys. Let's see here.
I call you
Okay, there we go. Okay, so then the HSTs, the Knox T3 is a very good device, and it does measure upper airway resistance and re-res. There's watch pads, the Aries, there's all kinds of HSTs out there. But again, I think the best way to handle that is just to seek guidance from a physician that you're working with. And then there's novel technology. And I'm going to talk just a moment about the Gem Pro. I was so frustrated with the barriers that dentists faced with trying to screen or assess patients using medical diagnostic instruments. I created a dental instrument, and it's called the Gem Pro, and it's designed to give you a sense of, okay, what's going on with the patient with their snoring, their blood oxygen level, their parafunction and bruxism, and by body position. And so this was a way to work around all these barriers that the medical community was saying, oh, dentist, you can't do that. That's practicing medicine. So we came up with that device. Real quick, this is a check me oximeter. The reason I like it is it has that cool sensor, that thumb sensor. So ring sensor, it's comfortable and reliable. And the device has a number of features. It has motion graph, so it can kind of tell if how much you were moving during the night. We do sell the oximeter. It's $299, and if you're interested and you want to know more information about it, by all means, give me a call or go to DDME online. Love to tell you about it. It's a great instrument. Again, I have a lot of experience with human sleep, and that's one of the better oximeters available. I did also want to mention that Ken and Steve are going to be doing a conference at the ADA in September. DDME is going to do a one-day, it's actually a half-a-day workshop at Glidewell. DDME and Glidewell do quite a number of things together. And the workshop's going to be, developing a procedure in your practice to screen patients. We're going to cover a number of topics. And for $399, you're going to get a full 5 hours of instruction on just screening patients. And that includes, the $399 includes an oximeter. And so, if you're thinking about screening and you're saying, geez, Ken and Jeff are, it's causing me to think, and you want to schedule a trip to Irvine in August, give us a call. You can go to the website here. And then finally, and most importantly, I did want to talk about this noted author that I know. His name's Dr. Ken Berley, and actually Steve Carstensen, who was on the call earlier. Together they wrote a book called The Clinical Handbook for Dental Sleep Medicine. And this is a great read. It has excellent, well-informed guidance through the various processes that a dentist should go through when they're treating their patients who've been diagnosed with sleep apnea. And I worked with Glidewell. And if you go through Glidewell, they'll give you a 25% discount. So it's like $54 for the book. And if you go anywhere else, it's nowhere near that. So if you're thinking about getting that book, there's the link at the bottom of the page. And I am going to send everybody a copy of the presentation that I gave, and it will have that link. But I encourage you to go to, if you're interested in the book, go to the Glidewell website, and you'll get 25% off, which is a pretty good deal. Okay, so that's what I wanted to talk about today. Ken, I want to say that we only went over by 10 minutes. So I'm very proud of us for that, because we're both known to go long.
Long-winded.
Yeah. And so at this point, what I wanted to do, I've been kind of answering questions throughout the webinar, but if anybody wants to kind of unmute themselves and ask a question or want to type out a question, I'm going to stay on for the next couple of minutes, and I'd be very happy to have a conversation. I'm sure Ken would be happy as well. And if you're going to log off now, I did want to give you a sincere thanks for attending. And if you're interested in the book, by all means, visit the website, or if you want to come out to Irvine and start screening, we'll teach you how. All right, August 2nd and 3rd. So Lawrence, if you're still on, yeah, it looks like you still are. August 2nd. Oh, that one's in Atlanta. I think John Tucker has one. Louisville, yep. September 6th and 7th in Louisville, right there. Okay. Yep. So hopefully you can make it to one of those. And yeah, I go to those, so it'd be nice to meet you in person. Okay, so John, let's see. It seems to me that a great deal of the regulation placed on the system is designed to restrict and limit care while hiding behind the phrase that it's meant to improve the quality of care. Yeah, John, I think that is a fair way that it appears, and yeah, I think that they're pretty transparent when they use the word encroachment by dentists. So encroachment is a term that means that you're kind of coming into my space. So I think, the way you're seeing that and the terms they're using to describe the situation, one could certainly say that. And it's, I've been, observing this for coming on 10 years, and I think they're having the opposite effect of what they would like, which is if they would cooperate, I believe that the referral pattern would be much more greased, and they would probably see more activity and more business instead of kind of coveting the diagnostic space the way it is now. But I suspect that will be changing. Okay, good questions. Yeah. Okay. Yeah. Reggie White. Yeah. Yeah. I'll tell you a story that I had, and I used to do quite a bit of legal sleep studies for people that had injured or killed somebody in a car accident, and there was a lawsuit, and we were determining the presence or not of a sleep disorder as we're trying to assign blame, the percent blame on the person that had the accident. And what the case that I'm thinking of is a truck driver fell asleep. He rear-ended a car and then pushed that car into another car, and two people died in that second car. And the individual had been diagnosed but had never been set up on CPAP. So they were his attorney, and I think rightly so, was trying to say, okay, yeah, there's some amount of this that is on the lack of therapy that was not implemented, and the patient continued to drive their truck even though they had initiated a treatment by going to a sleep lab. And I forget the outcome of that case, but it was horrible because there were deaths involved, and it was X percent on the driver and then X percent actually on the DME company that was negligent in getting him the CPAP in a timely fashion. So that's the type of situation that occurs. And I would say that it's rare, especially now. I think people have a good idea what it takes to protect yourself against outcomes like that. Yeah, John, let's see. I think I can't hear you. I don't know if you've been trying to put your.
Can you hear me
there
now?
You go. Yeah, there you go.
So may I say something here a moment?
Oh, for sure, absolutely.
So it kind of seems to me that we definitely need the rules and regulations and stay within our scope of practice, and I'm all in favor of that process. But sometimes the system will take and deny reimbursement or deny treatment because of the sequence things are done in. One particular example would be that a situation I deal with in my community. Oftentimes I'll get a patient that is CPAP non-compliant referred to me from a physician, and they're non-Medicare, so same and similar is not an issue. And when we go back in the records, the physician ordered an HST or a polysomnogram without a face-on-face with the patient, and they managed to get him on a CPAP. But then when I get to the oral appliance months down the road, everything's denied because the physician didn't have a face-on-face prior to the sleep study. It's not that they don't have sleep apnea. They clearly have sleep disordered breathing, but the system is just looking for reasons to not treat patients that clearly need treatment. and it seems kind of something that perhaps we could try to address, but it would be very difficult. So,
John, can I speak to that?
Yes, please do.
That is an incredibly frustrating part of doing this on a regular basis. And I didn't mention it in the lecture, but we actually now have a consulting company to help practitioners avoid those things. But believe it or not, that's our fault when that happens, because sleep physicians are literally given a totally different field that they play on. Most medical insurance companies, especially when we're relatively new to this, we're under medical review on everything that we do. So literally, we have to go in and dot every I, cross every T. And like, for example, if you looked at our documentation that we use in our office, my wife takes every sleep study, every patient that's referred to us, goes in, pulls all of their records, goes through, and we have a checklist. You know, have they had a face-to-face? Have they had this? Have they had that? And if they haven't, we actually go back to the patient. She makes a call to the patient and says, you know, unfortunately for us to do this, we're going to have to refer you back to a sleep physician or to a sleep physician. Dot all the I's, cross all the T's, because the sad thing is when you go in and do the procedure, now you've got the cost invested in producing the oral appliance. The patient's expecting some type of benefit and they don't get it. Well, if they don't get that benefit, and especially we've gone through the procedure, then it leaves a bad taste in the patient's mouth. So especially when you're first beginning to work with an insurance company, literally everything you do is being checked, and every box is being checked off. And sadly, most dentists doing dental sleep medicine haven't been adequately trained and don't have the appropriate systems in place to keep this kind of thing from biting them. You just have to have the checklist. You have to have the documentation lists checked off to make sure that this patient is going to qualify. The same thing on the definition of whether or not they have an AHI above 15 or whether or not they qualify by having an appropriate comorbid disease. I've seen that come back and bite a bunch of people. So yeah, all of these things are just things that you have to have a designated person in your office that is extremely familiar with the protocol for that insurance company, the requirements to qualify for OAT, and make sure that each one of those requirements have been checked off.
Can I say
we don't have much of a problem catching that, but it's after the fact, because and so we know it before we make an appliance, but the physician has somewhat made that error unknowingly. My sleep physician never does. I don't have a problem with that. We only have one sleep physician in the state, so
oh wow.
So we end up with a lot of primary care physicians' hands in it. The last one I dealt with, and I'll be real brief here. The last one I dealt with was last week. A primary care physician sent me a patient, and in their clinic, and the patient had their CPAP taken back by Medicare because they didn't meet the 90 days issue. And in the physician's note, there was a request to their staff to have an office visit with the patient after 90 days per Medicare guidelines. Obviously, those are not Medicare guidelines. So yeah, I've insulated myself from from getting stung with that, but it keeps me from treating patients too, because oftentimes if there wasn't a face-on-face, the insurance carrier wants the patient to go back to the sleep lab. So anyway, enough said there. Sorry to take up the time.
Well,
Kristen, did you want to say something?
well, Jeff, this is Patty.
Oh,
And
okay. Hi, Patty.
Hey, hon, I was just going to say to that thing, I had to call a sleep physician's office this afternoon before I left. We had done one of the screenings with the Knox T3 just to see. It was one of our patients, a dental patient. We sent them to the sleep physician per Ken's protocol that he was telling y'all about. That sleep physician used that Knox T3 and sent us a prescription. Well, it's a Medicare patient. I had to call the sleep physician's office this afternoon and let them know that it was not a qualified Medicare study. So what Ken was saying is, and I understand I believe it was John that just was speaking, but you got to have somebody in your office that knows exactly what they're looking at before it ever comes, that the appliance is made, and yet not be afraid to pick up the office and call and speak to the nurse of the doctor or the nurse practitioner or whoever and say, I'm so sorry, I'm not sure what I'm supposed to do with this because it's not a Medicare approved. I'm sorry, what? So anyway, you just got to have somebody in your office and that I just thought it was rather strange that just happened before we got on here. So sorry, Jeff.
No, it's a timely, and unfortunately it's not uncommon, especially Medicare seems to make it, they have their own level of grief that they add to the system. All right, well, it's about 5:30, guys, and it's unless there's kind of any other questions or discussions we want to have, we're going to call it a day. What'll happen next is I'm going to end the recording, and then the thank you email with a link to the recording of this session, and there'll be a couple other links to get the Dr. Berley and Dr. Karstenson's book at a 25% discount, and then if you're interested in coming to our workshop August 16th in Irvine. It's a great area, close to the beach. By all means, we'd love to have you there and get to meet you in person. Okay, thanks a lot, everybody. Have a great day.